first of all, thanks for reaching out at the course.
Yeah.
Yeah, I mean, you just kind of shot me a message and said, "Hey, stoked about using the content so far
hmm
in practice." And so, I guess my first question is, out of curiosity, like, what was it in those first few days that kind of made you so excited about it?
I think a lot of it's just, especially when I took the course, my first year out of practice, like 7 years ago, and just having a retouch on a lot of it, and then also having the material a little bit slower digested with doing some of the coursework online at my own rate beforehand, and then so it wasn't nearly as overwhelming. Also,
Yeah.
only having 2 days in person as opposed to 4 days in person, that was
Hmm.
felt like I was able to retain a lot more of the information and just like, oh hey, we're highlighting things that we'd already learned in lecture rather than trying to cover everything in a very tightly truncated time frame.
Hmm.
So it is just a lot more digestible, especially like coming back into practice and then being like, oh, wait, here's an upward sliding dysfunction case. Well, cool. I'm following up with her tomorrow. And I was able to go review those videos and really see exactly which techniques I need to be doing and making sure my mindset was correct in applying it. Or even with some carpal tunnel ones, making sure I'm getting those movements down, or even going through reviewing their palpations, all of that kind of stuff, because it is a lot to absorb. So having the ability to go back and review those kinds of things is a huge help, especially because how often do some of these cases pop up? I mean, it's not all the time. It's not like you're coming in and having
Yeah,
three
if
carpal
you
tunnel people on Monday.
totally, yeah,
And if you
unless you
do, you're
have,
missing all these other cases.
yeah, yeah,
You're not going to have
and
three of those and three tarsal tunnel patients on the same day.
yeah,
So
totally.
getting enough touches, so having that material is a huge benefit.
Uh-huh. Yeah, I know. Unless you are literally a neurologist who evaluates MSK-based peripheral nerve injuries all day long, you might go a month before it would be indicated to do a serial neurodynamic test.
Right.
So that actually was a similar challenge that I had. I'm super fortunate that I got to take the course multiple times to kind of go over that material as an organizer. But I do think that the hybrid model of teaching this course with the theory taught beforehand, a practical focus in the in-person course, and then having the videos
Mm-hmm.
afterwards is a huge strength of the way we're delivering it now in terms of learning outcomes.
Yeah. Well, and the reality is, like, even in some of those cases where you're like, oh, this is the presentation, like for the upward sliding dysfunction, which is really weird to see. It messes with your head when you, like we had talked about in the course,
Hmm.
when you first see that. And then it's like, you just talk to the patient, like, hey, we're going to do this today. Because I know, like, it might be, like, I think we did some 3 month supine breathing stuff and some other things like that. But I know where to find the information that we ultimately need to do to help get get your nervous system moving better. And patients are also really cool with that, like just that you have confidence of, I don't necessarily know exactly what to do off the cuff at this moment, but I know where to find the information. And patients still appreciate that a ton.
Hmm. Have you had any pretty clear cases where you had seen in the past or had perhaps past misdiagnoses where you were able to kind of tease out with better application after taking it the second time around?
Yeah, I mean, while we were at the course, you and I had discussed a case of mine that I was currently working with, where it's right ischial tuberosity type pain, where it's deciphering between, hey, is this more of a neurodynamic issue, or is it more of a local proximal strain? And in reality, it's definitely a neurodynamic case. And that's where, for me, one of the things that's hard is figuring out, like, localizing the source of involvement,
Hmm.
which for them, like, you can definitely tell as we went through and did a bunch of sliding more through the piriformis region and all that, the tenderness palpation, I mean, was probably 70-80% decrease within visit. Um, some of those, it's kind of hard for them to figure out how to get them to maintain that progress at home. is a little bit
Mm-hmm.
challenging, especially when you have to be a little bit nuanced with their positioning and the movements. So that's one of the things that I'm struggling with right now is really communicating how for them to make sure that they're actually doing some of the movements correctly at home, or some
Mm-hmm.
of the supported stuff, making sure like they aren't crossing their legs or something like that that can really be causing more of the irritation. So some of the ADL modification side of it for those that actually become important as well.
Mm-hmm.
Because oh hey cool we can calm it down, but can we get you to stop pissing it off all day?
Yeah, I mean, like understanding the mechanisms that underpin the
Mm-hmm.
patient's chief complaint and then understanding the level at which they're presenting at you with allows you to obviously target exercise interventions in clinic treatments, but also something that they need to be considering in terms of ergonomics and or positions that they're putting themselves in that might be provoking it. I think you're the one that actually mentioned that your late friend who was a surgeon expressed to you
Mm-hmm.
that if we could just fix people's sleeping position, the vast majority of carpal tunnel syndrome cases would never go to surgery.
Right.
Um, so that's certainly pertinent for sure.
Mm-hmm.
Have you been integrating like exercise, DNS, and NDS into like you feel like you're into a cohesive unit?
I wouldn't say anything's 100% cohesive yet. Uh, I'm definitely understanding some of the concepts you're talking about, and there are aspects where in some of these cases, like I feel like we can get them progressed in the right manner a little bit quicker, or like with modification. So doing a little bit more unilateral stuff in certain cases, uh, where we might be going into a little bit of a hip hinge pattern while we're providing the protection with the opposite side.
Mm-hmm.
So some of those kinds of things I've been able to do, and you can totally start training some of these ADL patterns that might be a little bit. Um, it's just a little bit easier to train it without flaring them up. So there are some strategies. I'm not 100% confident with how to address some of those things, and I know that like one of the things is trying to find the right exercise. So for example, okay, cool, you have someone who has potentially a thoracic outlet region issue. Well, you might be trying to put them into a 3 month prone position, but if you're over cueing the scapular depression component, you're just going to create more issues from that standpoint. So trying, like, I think that's one of the issues that I've had in the past with 3 month is over cueing scapular depression to where you're actually getting neural symptoms. So,
Mm-hmm.
hey, if I like being able to pair the right exercise with those patients definitely is better, especially if I know like this is not good going into an ulnar position. Well, maybe loading it in this position is probably not the best move for us right now.
Yeah, and if people have a limitation in the ability to tolerate tension,
Mm-hmm.
the prone 3 months position is a position of ulnar nerve tension,
Mm-hmm.
less for some than others, right? But if they
Mm-hmm.
have pertinent medial cord or ulnar nerve problem, it's gonna flare it. I actually, DNS obviously is focused on optimal posture, but understanding that sometimes optimal posture is a contraindication to the
Mm-hmm.
neurodynamic presentation is super important.
Yeah.
And it's like, okay, postural mechanisms might be the underlying factor that brought this condition on to begin with, postural or movement-based factors, but that doesn't mean that you need to address that first. And that
Mm-hmm.
goes into understanding like the level of the patient's complaint. If they're a level one patient presentation and they have persistent and continuous symptoms, or it's easily provoked or aggravated, then you need to start them in positions of offloading, in which case I would actually be cueing them towards scapular elevation, not depression.
Mm-hmm.
And keep
Yeah.
in mind, like in my experience, the majority of patients with subclavicular or corticopectoral tunnel syndrome thoracic outlet variants, obviously neurogenic in nature, they're usually going to respond really well to things that would be antagonistic to depression. So landmine press, a high bear position with an accentuation towards a shoulder shrug position. I had a guy actually a few years ago who he had actually stopped going to chiropractic school because his thoracic outlet syndrome was so persistently aggravated by both practicing in lab, like chiropractic techniques, but also just being a student. And unfortunately, he wasn't able to be helped in the clinics or by students or clinician practitioners. And yeah, he ended up essentially leaving chiropractic school because he couldn't get a hold of this thing. He ended up becoming a personal trainer, pretty bright guy, but still had pretty persistent TOS symptoms when I saw him. And I actually only saw him twice. But with teaching him the basic principles of offloading and then progressive adaptation and reloading, he actually kind of was able to figure it out on himself. And we had touched base on social media, I think it was like 6 months ago. And it was like, hey, yeah, like, how's your TOS? You know, he's like, oh yeah, that fully resolved. I was able to just use the principles you taught me and fully resolve that condition, which is pretty crazy. I think at that point, when I first saw him, he was like 4 or 5 or 6 years in to this persistent condition. So I think, unfortunately, what happens is we have good intentions in normalizing some specific postural dysfunction or movement pattern dysfunction, but it kind of keeps that patient's sensitivity, going, right? So, yeah.
Yeah, precisely. Especially, you look at it, and a lot of those postural reactions and postural positions can be because it's a protective mechanism for the patient. So if you go into a protective mechanism for some of them, then and you try to train them out of it because it's so easily irritable, I don't know how you have to calm it down first.
Yeah, actually, in my experience, the people who have positive protective patterns actually don't usually come in with a level 1 presentation because they're very good at self-relieving. So they'll come in with more intermittent problem because they naturally acquire a position of perhaps what would look to or appear to be a shoulder shrug, an elevation of the scapula. Or protraction with elevation of the scapula. And then you would see that as being, quote unquote, a pathology. You try to correct it. And unfortunately, it tends to provoke those symptoms. The thing is that provocation isn't always immediate. They can feel minimal provocation in the moment, but it just a little bit pokes and prods it. And as they continue to practice that, it can a little bit get more and more sensitive over a period of like 3, 4, 6 weeks. And they don't necessarily put the 2 and 2 together because it's not always an immediate provocation. I think the flip side of that spectrum is the patients who I generally notice that have a more persistent presentation are those who have a maladaptive position in their shoulder girdle in which their scapula is down rotated and or depressed. Sometimes it's actually in a position of down rotation and retraction. Either way, that's a position that closes the interface of the brachial plexus relative to either the subcostal space and the clavicle or the corticopectoral tunnel. The other thing to consider is that you're actually also tensioning the brachial plexus at the scalene triangle. Furthermore, these patients often have stabilization and movement pattern dysfunction, which facilitates those muscles that tend to create persistent hypertonicity and load the brachial plexus in those areas. So TOS is a super interesting condition to treat because you have essentially 3 different potential areas of irritation, compression, and sensitivity, i.e. scalene triangle, subclavicular space, and corticopectoral tunnel. And sometimes they'll present with 2 of those 3 as pertinent mechanisms. Sometimes they'll only present with 1 of those 3, and sometimes all 3 are screwed. So you need to either address 1 or all of them, right? Depending on the presentation.
And how are you deciphering between those three? Is it primarily through palpation aspects or?
Yeah, I'd say it's the whole battery of the exam, starting from just standing postural exam,
Yeah.
range of motion assessment, putting them into positions of stabilization, putting them actually into their work-related posture that tends to provoke their symptoms, understanding the mechanics of provocation or easing factors as well. And then, yeah, like cervical spine, rule it out.
Mm-hmm.
Have a look at the mechanics of the cervical thoracic spine, which unfortunately, usually in TOS, you don't have amazing cervical thoracic mechanics to begin with.
Yeah.
So it doesn't necessarily pull you out of it being cervical genic, right?
Yeah.
Um, and sometimes it's both, right? As we said in the course, like patient deserves the right to have more than one. And sometimes you have more than one mechanism at play, this, with the cervical spine potentially being one variable within that. But as you go through your exam and collect all the pertinent data points, range of motion and stabilization function, a static postural exam, work-related postures, easing and provoking factors, palpation of the brachial plexus, both at the scalene triangle, palpation of the scalenes, as well as
Mm-hmm.
actually like omohyoid, can be
Mm-hmm.
pertinent in that area. Palpation of the brachial plexus as it comes out of the subcostal space, just inferior lateral to the clavicle. Tone, texture, density, or thickness of the fascia and the muscle through the pectoral region. Actually going into the axilla and palpating the axilla
Mm-hmm.
through the axillary space and the axillary fascia. I find sometimes it's super helpful to do as we did in the course. We did a median neurodynamic technique while palpating the brachial plexus in and around the scalene triangle, just superior to the
Mm-hmm.
clavicle. You can do the exact same thing with your hand into the axillary fascia and palpating the brachial plexus in that space. All of that is pertinent, right? And then from that information, you should be able to tease out the most pertinent mechanisms at play, right?
Yeah.
Now,
Yeah. I've one of those cases here recently. I was left side thoracic outlet issue, several years post op on uh, a shoulder surgery. But it was interesting because like the first day we were working on it, it was very much so median nerve was clearly involved in doing our neurodynamic testing. Very, very asymmetrical, to cause provocation. And then the next visit, like that was way better. Symptoms were a lot better. But then it's like, oh hey, now ulnar nerve actually becomes a little bit more involved for him. So it's kind of interesting on some of those kind of cases where you have more neural structures. You kind of have to tease out a bit more. So that was kind of a really interesting one that I totally would have missed. I feel like if I wasn't really being like, okay, well, this is better, but let's go ahead and test everything else. Um,
yeah,
yeah,
I mean the
some of that
crazy
stuff's
thing
really
with
interesting.
TOS is you could have, if you're talking scalene triangle, you could have upper, middle, and lower trunk, or one of those three, or two of those three.
Mm-hmm.
If you're talking subclavicular space, that's more in the area of the cords, as they're dividing and ultimately becoming peripheral nerves in the axilla, just distal to the clavicle. So if you're talking a subcostal compression and irritation, then again, it could involve all cords or one of the
Mm-hmm.
three. And then as you get into the axilla and corticopectoral tunnel, then you're talking about the divisions into the peripheral nerves, which again could involve one, two, three, or four of those peripheral
Mm-hmm.
nerves. It just depends on the patient, right? So, I had a patient not too long ago. Her dominant presentation was pins and needles, occasionally numbness and pain in the distribution of like C7-8, so ulnar nerve. Um, and her other predominant presentation was actually lateral elbow pain in the distribution of C6. And I feel like she probably had a primary scalene syndrome with a secondary subcostal space. And at that point, because it had been so chronic, there's always the potential for aberrant tone, texture, and function of the soft
Mm-hmm.
tissues of those that of the muscles that those nerves innervate. But it's pretty interesting when you start palpating the proportional activity of the muscles in the neck region in these patients, because she had such significant overactivity of the scalenes. And honestly, I kind of feel like there was an anatomical variant there, like a scalene minimus, or some kind of like an abnormal variant of omohyoid, potentially a fascial adhesion between them, because I could feel a pretty firm fascial structure that moved with contraction.
Hmm.
That felt like it contracted underneath my hand, but literally lay right over top of the brachial plexus, just around the scalene triangle and distal to it. It makes these cases sometimes quite complex to manage, and you have to kind of address all variables. But what tends to be fairly universal with with regards to relief is if you put them into a thoracic outlet opening position, interface opening position, uh, as per Shacklock's described, it's almost always relieving.
Hmm.
If you put them
Yeah.
in a nerve offloading position and you combine or couple that with static openers in the thoracic outlet and respect the process of desensitization while you're kind of gently and slowly figuring out the mechanics of their condition, which in this case, by the way, was essentially scapulothoracic rehabilitation towards the position of elevation. So actually
Hmm.
getting more elevation, more upward rotation, less depression, less downward rotation. But the second we started to load her neck, i.e., lift your head from the floor, do a sit up, get up from the ground, um, hang from rings or a TRX, it just lit her right up. So we almost had to like peel back and totally readdress the scalene component of her condition. She had been doing so well with everything that we did prior, but then as we started to reload her and go into rehab,
Hmm.
that seemed to be a much more primary part of her clinical picture. And thankfully, she responded quite well to that. And just to quiz you a little bit, just for fun, if you have an overactivation in the left side, and the scalenes are at this point incapable of not overactivating and compressing the brachial plexus, if you're in DNS land, where would you go with that?
If we're trying to decrease activation on the scalenes.
So let's assume your clinical picture is this patient has depressed or downwardly rotated scapula or both.
Hmm.
They have significant anterior head carriage in cervical extension. They have very poor integration of deep neck flexors where they pretty much
Hmm.
just like buckle into their cervical spine in an extension pattern with the upper thoracic spine moving into flexion as they look up, which is paradoxical, of course. They have limited rotation and lateral flexion. They have significant hypertonicity of all the muscles in the left lateral neck, levator
Yeah.
scapulae, upper trapezius, scalenes, pec minor, pec major. Brachial plexus is 3 out of 4 tender, so significantly tender to palpation and touch. Radiating pain into the lateral elbow, pins and needles, and occasionally numbness into the fourth and fifth fingers. So, like, where do you start with that, right?
My initial thought on that to decrease the tone in that left side would be to go into side lying on the left with some rotation
Mm.
to calm that down. Uh, that would be my first thought. And once again, just not over cueing depression, kind of like what I was talking about earlier. But that's my initial position.
Love it.
Um, yeah,
So you want to know what I did?
yeah. What'd you do?
uh, I did high bear first, and I coupled
Mhm.
that with static openers and nerve offloaders. Was really well tolerated. We were able to move that into a low kneeling variant of a high bear, so off elbows, which was just more challenging and difficult.
Mhm.
And then, yeah, we actually did exactly that. We went into the opposite side, lying leg raise, so supporting on the symptomatic side
Mhm.
to ensure that you essentially have relaxation of the left lateral neck muscles, but at the same time facilitating stabilization function of the shoulder girdle of the rotator cuff. And I actually added load into extension. So
Mhm.
in the office, that's manual resistance into extension to further calm down the anterior lateral neck muscles. And then as homework, just wrap a band from the supporting arm around the back of the neck or the head to the phasic function upper extremity. And
Hmm.
yeah, that's pretty much exactly what I did.
So
And
you
then
started in high bear and then went down?
yeah, yeah, and you know what I mean. I certainly can't say that either way wouldn't have been equally effective. I think both
Yeah.
were pretty well tolerated, and we're not talking like a long delay here. It's like first
Hmm.
session, nerve offloading, static openers, get a positive response. Was able to get her pain down to like a 1-0 just with that, and then. This patient actually is not from Victoria, so I didn't have like limited time to work with her. I
Hmm.
had a few weeks while she was staying in Victoria to visit with family. So I knew that we had to be incredibly efficient, and she had to go home with a complete rehab strategy in place. Small
Hmm.
community, not a lot of people in her neighborhood that could really help her out. So I wanted to kind of fast track as much as I could. So even in the first session, high bear, really well tolerated, but I
Hmm.
biased elevation. You know, this is not a
Yeah.
situation in which you're at all trying to depress the scapula. And to be honest, I don't think that's ever appropriate in a bear position or a high bear. Like I think it's quite natural for the scapula to elevate and upwardly
Hmm.
rotate as you're doing those things. But she tolerated that really, really well. And then, you know, next session in sideline, you know,
Hmm.
next session in off elbows in a high bear, next session in throw in like a single arm kettlebell front rack position, which a little bit like props the scapula up and forces her to maintain elevation and upward rotation. Next session in goblet squat, next session in
Hmm.
throw in a little bit of closing mechanisms, but limit it with a row. You know what I
Hmm.
mean? So essentially, like a split stance row or any row for that matter, you're starting to get into a closing mechanism with retraction of the scapula, assuming you're
Hmm.
finishing in that position, right? Which footnote you don't have to. You know, if you want to
Yeah.
integrate into a pulling pattern, you don't need to finish the movement if they have a significant closing dysfunction at the subclavicular space or the corticopectoral tunnel. You can wait to approach that loading mechanism before you go there.
Hmm.
So, you know, the goal, in my opinion, is always to have a well-rounded program that trains a human to function well. And that's irregardless of the injury that they present with. So, you know, in her case, she's keen. She has a history of actually bodybuilding when she was like high school and afterwards. Hadn't been doing it in a while, but she was keen to get back into it, but just didn't know how, right? Like she
Hmm.
was everything that she did prior to that provoked her. And unfortunately, the practitioners that she had seen previously didn't understand the relationship between the contraindication of quote unquote good posture, which they're defining as the shoulder sits down and back, which in my opinion is not necessarily the good posture, but nonetheless,
Right.
they're defining the correction with like a Brugger's relief position or an open book position in which they're retracting the scapula and depressing it and retracting the cervical spine. Well, all of that was provocative for her because
Hmm.
that's a closing position for that interface, right? Um, so sometimes the best of intentions in a reasonable exercise are really, you know, misplaced in a patient with that presentation.
Yeah.
Yeah. Anyways, we've kind of gotten sidetracked on the thoracic outlet syndrome, but it's
Well,
an
and
yeah,
a little bit on that note, like I had, I think it was probably 2 weeks ago, I had back-to-back new patients that were both, you know, moms with one was had a 3-year-old, a 1-year-old, and a 1 month old, and the other one had a 1-year-old, and both of them it was, oh hey, I have raging arm pain. One was bilaterally, one was unilateral, and the bilateral one literally stood there like this when we had her stand up to go just do cervical range of motion exam,
yeah,
and then you just lay them on their back and just have them actually come into some offloading position. But like for those patients, if they're carrying children and just being tractioned all day long,
mm,
like it's so honestly simple to
yeah,
just teach them some of the offloading maneuvers, or hey, like propping up and giving yourself support if you're seated holding your child.
yeah,
Make sure you get pillows and just some very simple techniques. Once again, like we were talking earlier, if you understand some of the mechanisms of provocation,
yeah,
it can be relatively easy to address some of those. And I think that's where, like for me, one of the aspects is that patient communication component is definitely improved. Or like I've
Mhm.
got one that she's 6 months post microdiscectomy, and then
Yeah.
full on contralateral lateral shift now.
Yeah.
And it's like, hey, yeah, we actually need drugs on board to address, this inflammatory component.
Yeah.
All of those kinds of things, which it's interesting to me. I never really thought about it from the factor of like, okay, you get the neurogenic inflammation. If the nerve is now bigger, then it also becomes a space occupying lesion itself, not even to just factor into the aspect of intraneural pressure from pushing outward. But if
Hmm.
the nerve itself is engorged, then it becomes a space occupying lesion on top of if there is ligamentum flavum or if there's any sort of disc protrusion, whatever it is.
Hmm.
But I just never really thought about that component of it.
Yeah. Yeah. I mean, it's the thing about neuropathic pain specific to peripheral nerve injuries is that our understanding of the mechanisms of these injuries is actually pretty good.
Mm-hmm.
It's not like we have a fuzzy understanding of what causes these peripheral nerve injuries. The mechanisms are pretty clear. As Shacklock would say, the be happy, move more philosophy with these patients sometimes is quite silly actually when you understand the
Mm-hmm.
mechanisms. It's also can be quite silly to approach a radicular patient like that. I'm not saying it's always contraindicated, but it can be contraindicated and quite silly to approach that particular patient with closing mechanisms. When you
Mm-hmm.
understand the mechanisms at play, is that the closing dysfunction, the nature of the injury, the compression of the nerve, and the engorgement of it is literally the defined and known pathophysiological mechanism for that patient's chief complaint pain. And man, does it make your life so much easier and your patient's lives so much easier when you understand those mechanisms and can give them the
Mm-hmm.
necessary relief early on to prevent them from transitioning into a chronic pain presentation,
Right.
you know?
Well, and
So,
that one's actually a good example for integrating neurodynamics with DNS because for her, yes, sidelining openers were great. Those helped a ton. Static openers are great. Going into some of our level one progressions helped a ton. Actually, what helped her myotomal strength the most was breathing and just static breathing and low kneeling, and really getting even more into the sagittal plane, opening up for her was even more effective. And
mhm.
then for her in that position, we were able to go into quadruped and work into some 6 month rocking, and then just to work on, hey, actually going into hip extension instead of lumbar extension, so avoiding or closing mechanisms, and then going into retraining with in a flex position, hands up on the wall, and then being able to stand up tall like we were in 6 months, and actually get and create hip extension instead of lumbar extension. So from that standpoint, that's one that's really straightforward on how to address it using both principles.
Yeah, man. Love it. It's fun to play with principles when you can help people. It's for sure.
Yeah.
Yeah.
So for you as an instructor, do you have like particular goals that you want people to be able to apply initially coming out of the courses? What are you hoping people can do pretty early on?
I mean, for me, that level one presentation is so critical and so often missed. Understanding how to offload an acute and irritable nerve. And acute and irritable, by the way, doesn't mean it just started yesterday. You can have
Mm-hmm.
people with a level one irritable presentation, and they're, perhaps years into that condition in some cases, right? So, anyways, understanding how to manage that presentation, I think, is essential to transitioning into essentially rehab, right?
Mm-hmm.
So yeah, I think it's super important. Yeah, anyways, I'm super curious. um, to know how students, how participants, how practitioners integrate information into clinical practice. I think that's um, a huge deficit actually in the way that we engage in continuing education is the integration of the knowledge and the skills that we actually receive. And listen, there's, I think, a fairly broad variance um, in how well people do that, but it's hard. Like, when you're
Hmm.
running a full-time practice, and in your case, more than one clinic, you have family considerations, you have commitments. Uh, when you come out of a course, it's not like you're going home and you're studying, you know,
Hmm.
all week. You have other things that you're doing, and um, I think it is challenging to adequately integrate knowledge and skills, or new knowledge and new skills, into clinical practice. And the research is pretty clear on that. We don't have a lot of research on chiropractic practitioners, but I don't think it's that much different than our medical cohorts. In the medical world, the research would tell us that the 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 methods of practice of a practitioner that graduates in 1989 are similar to the methods of their practice when they retire in 2022. You know what I mean? Like they don't actually change how they practice that much throughout their career. And I think that's a challenge, because I actually think we should be
Hmm.
evolving considerably as we go throughout our career. I know for sure I have similar core principles. I've always integrated exercise, always integrated manual therapy into exercise. Um, I always thought, communicating and building relationships with patients is important, but how I've done that through my career has gotten so much better, so much more efficient. I've gotten so much more um, knowledge and skills that I think make me a very different practitioner today than I was
Hmm.
20 years ago. So, anyways, long story short is I'm just super interested to see how you integrate the knowledge of the course that we just did in neurodynamics, and and how you're integrating into your practice, how you're consuming the information, and tying it in. And you've alluded to it already, and I think that's
Hmm.
beautiful that you fully utilized the content from the theory before the in-person course. That you felt that you were able to go into that course with your eyes wide open and consume that content a lot more readily. Certainly helps that you had another exposure prior to that, I'm sure. But the video library that you have access to for a couple of months after the course, that you've already been accessing, because you know that you're not going to remember everything that we did in that weekend, but at least you got that kind of first introduction, roll through the mechanics of it, and then you can go back and reference it after the fact when you have a patient presentation that piques that memory of, oh yeah, we did this in the course. I'm just not 100% certain how I do that. So
Yeah.
that's kind of what I'm curious about, is like how practitioners are walking out of a course and ultimately integrated into practice.
Yeah, I think there's a lot of ways to approach that. First thing, like if you don't have any exposure, like you just need to be able to learn how to do the techniques appropriately.
Mm-hmm.
So even just for me, it was a week or so of just figuring out my hand positions on the different, well, really both upper and lower extremities. Just
Yeah.
figuring out those hand positions, getting enough reps so that it becomes more natural to do the tests. And then your technique has to get really good and really specific and really consistent for the test to really mean much. So if you can first off just get better at doing the tests, then you can start actually figuring out what information you can get from it. So the techniques on that, and then technique on like going through a bunch of your nerve palpation. I think those two, from a skill standpoint, almost have to be first before you can even get some of the clinical mindset behind it, because otherwise you're just using aberrant clinical information if you're not able to do some of those base skills.
Oh,
Um,
I love that point. I think you need to pause on that. So,
yeah.
what you just said a moment ago was that the skill of performing a precise and adequate test allowed you to consume the information from the patient that then built in clinical reasoning. And if you didn't
Mhm.
have that accurate information, you wouldn't be able to transition into the level of clinical reasoning that you would want. Um, that's I think that's I had a conversation with one of our associates in the office the other week, and I he first of all, tons of respect for him. Great chiropractor, excellent skills, builds rapport like no one other, the most likable guy in the world. Um, and anyways, we share patients, we collaborate together. He sees some of my patients, especially when I'm going away for courses or holidays, and vice versa. And I noticed when I was scanning through his chart notes that he wasn't including certain objective findings into his chart note. And I was fairly confident, knowing him pretty well, that he had actually observed those things that I was seeing when I
Hmm.
was seeing the patient, or had done that exam that he didn't seem to notate. That I thought, I'm surprised he didn't do that. And so I chatted with him about the other week, and he's like, "Oh yeah, I'm for sure seeing that." And I was like, the thing is, I get it, but that's not what your chart note says. And if you can't reference that, you actually don't have the data point to even know whether that's a mechanism or something that underlies the causal mechanism of that
Hmm.
patient's chief complaint. You know what I mean? It's like when people say that movement quality doesn't matter, but they don't actually have the skill set to even see what good movement is. It's like, how do
Hmm.
you even know? You know what I mean? Like
Hmm.
if you don't actually have the knowledge to observe what quality postural stabilization looks like, how do you know that it's not relevant to the patient when you actually haven't collected that data set?
Hmm.
You know what I mean?
Well, I mean, that's the
Um,
same issue with getting too much information and like, oh, hey, you get these scary MRIs that now you have this data set, but you still don't know whether or not it's 100% relevant. So from the other standpoint, you can also get clouded judgment from not being able to get the information, or you can get clouded judgment from getting too much information if you're just assuming that it's relevant and not actually
yeah,
being able to
that's a key
pair it.
transition though. That's a key transition because I
Yeah.
don't think it's the information that skews the objectivity and the reasoning basis for that information, right?
Hmm.
So like when we get an MRI, you and I get an MRI, we don't presume that the imaging that we see is correlated or causally related to the
Right.
patient's chief symptoms unless we have a clinical exam that correlates to the MRI findings,
Right.
which in a disc herniation is pretty freaking obvious.
Hmm.
But I'll give you a really good example. I had a patient who presented a day before vacation. The patient had local pain right over the area of the supraspinatus. It was like the size of a dime, but more rectangular in shape. It literally was like the shape of the tendon as it passes underneath the acromion. And he's pointing to the spot. He says, I've got pain when I reach into the cupboards and pull my coffee cup down. It hurts when I raise my arm overhead. If I sleep on my right side, it bothers me. He had no neurological signs or symptoms. Uh, but I had the fortunate, I guess, background that I'd seen this patient a few years prior. I kind of knew his neck wasn't perfect, based off of that prior exposure with him. So, like any practice should do, you do a comprehensive assessment. And sure enough, neurodynamic testing specifically provoked his chief complaint pain. So it was
Hmm.
overt abnormal. He also had significantly limited closing mechanisms of his cervical spine that also provoked his chief complaint pain. So it was very obvious to me based off the exam that this was not really a rotator cuff problem. And as I explained to the patient, I said, listen, like you might have some inflammation in the rotator cuff secondary to neurogenic inflammation of the nerve creating inflammation in the tissues. Obviously, I don't say neurogenic inflammation to the patient, but I explained that to him. Anyways, long story short, I give him these exercises because he's going away on holiday the next day. He's going to Mexico for
Hmm.
3 weeks. So he's on the route to Mexico. It gets really flared up. So combination of sitting, playing, carrying his luggage, etc., gets really aggravated. I think the aggravation persisted throughout his holiday. So when he gets back, he's a little freaked out. So he goes to instead of coming to see me because he's now worried, he needs to go see his doctor. He goes see his medical doctor. So again, the patient is local, right over his shoulder. So doctor says, okay, let's get an ultrasound. Gets the ultrasound. This is a 63-year-old male. The ultrasound demonstrates signs suggestive of a tendinopathy. So
Yeah.
thickening of the supraspinatus tendon, like what would it be called, a hyperechoic region within the supraspinatus, possible partial tear. Not definitive, but partial tear. So the medical doctor then refers him to a specialist shoulder practitioner. I won't say which professional, I'll just say a specialist shoulder practitioner. That specialist shoulder practitioner then proceeds to rehabilitate this patient as if they have a shoulder problem. The patient gets progressively worse throughout the course of rehabilitation. And this patient, by the way, super compliant. Like, he will do everything you tell him to do. He'll do all of his exercises. He'll do it all. He'll follow the treatment plan. So he sticks with treatment for like 12 weeks. And it gets to the point where he's not even sleeping at night. And he's like, screw this. I got to just stop doing everything. So he stops doing all of his exercises, stops going to the practitioner, and waits 8 months before it calms down pretty quickly after he stops doing the things, right? But now 8 months later, he still has like local pain over his shoulder with reaching into the cupboard, going behind his back, all the shoulder things.
Mhm.
So at this point, he now comes back to see me and he tells me this whole story. I'm like, okay, so let's re-examine to make sure that I wasn't wrong the first time around. Sure enough, he has 5 degrees of right lateral flexion and 10 degrees of extension, both
Yeah.
of which provoke his chief complaint pain. And he has an overtly abnormal radial and axillary neurodynamic test that reproduces chief complaint pain. We treat his cervical spine and the nerves that emanate from it. His pain fully resolves, and now he's doing totally fine.
Yeah.
But point being, as to what you're saying, is that the assumption was that because he had abnormal findings on ultrasound, that was the clinical diagnosis. But that was only because they didn't collect all the other data points to accurately interpret the presentation.
Yeah.
You know, it's not
Exactly.
the ultrasound's fault. The ultrasound was objectively accurate that he has a suggested asymptomatic tendinopathy, which is kind of normal in that age demographic. You just can't make the conclusion that that's what's causing his pain unless you do a really good physical exam to make sure that correlates to his presentation, in which case, in
Mhm.
this case, it did not, right? So,
Yeah.
yeah.
So a couple of other things I would say as far as applying it in practice. First off, getting your skills down. And then second thing, from a clinical and case specific standpoint, I mean, it's been really nice. Like, Kyle Thompson took the course the week after me. So Kyle and Max
Mm.
Pagliata and I, we all had like a little group text of just talking through different case presentations or just aspects of lecture and applying it clinically as they come up in practice. So I would definitely say, like, if you don't have people in your own clinic that you can talk through it with, then definitely find some other people who have taken the course with you and get a group thread going for a while. So you're not only just learning from your cases, but you can also learn from theirs.
Mm.
And certain things that you may be like, oh, I wouldn't have thought to apply or look at this particular thing like you did in that case. So you're actually learning from their clinical experience as well. I
Mm-hmm.
think that's been really helpful. And then also, like, dude, if you've got some cases that you're not making the benefit on, just schedule a freaking re-exam and take the time to actually go back and reassess stuff. And that can be a huge game changer as well.
Yeah.
So if they're not responding to the current techniques you're doing, just check it out. See if something might be a neurodynamic case, or like be a little bit patient. I've in a patient right now with Achilles tendinopathy issues, and it's like, look, we're just going to do some neurodynamic stuff and roll out spine, roll out neural involvement for the first session or two, just to make sure we're not going down the wrong pathway. Because if this is what it is, it will respond way quicker than the tendinopathy, and then
Mm-hmm.
I don't want to get weeks, months down the road into addressing a tendinopathy, and it potentially have actually been either lumbar or neurogenic involvement. So
Mm-hmm.
just take a little bit of time to even just rule it out, especially for something that's going to be a longer treatment.
Yeah, I mean, I think um, never assume that you're right, you know?
100%.
I think that's one of the hardest things to do in clinical practice is to persistently and continuously question yourself,
Hmm.
with a degree of optimism and confidence. Because, I know new grads coming out, it's like they probably question themselves way too much, right? Um, but uh, but yeah, I mean, be impatient, expect outcomes. When you don't see those outcomes, completely blank slate, perform a re-exam, assuming that you have never seen that patient before and you need to rehash
Hmm.
a better diagnosis, a better clinical reasoning, interpretation of the patient's presentation, et cetera. Something you said there I thought was super interesting. um, you have a group of colleagues that you call up to have conversations about this course. Thankfully, they had taken it a week after. I think that's actually, like, I wonder how many people give a call out to a colleague on a regular basis when they're not 100% sure about a patient's clinical presentation. I actually do it super regularly. Like,
Hmm.
I'm fortunate to have really smart people around me, but if I've seen a patient where I'm not 100% certain, I'm going to call Joe Gravino, who's another one of the neurodynamics instructor in Buffalo. I'm going to call Shacklock and be like, "Hey, Shacklock, like, what do you think of this?" Rich Alm, Brett Winchester, all the DNS crew, any of the Prague School physios, and my colleagues in practice. And like, I've mentored some of my associates, but I trust that they're going to ask really good questions. So
Hmm.
if I talk through a case with them, um, you know, sometimes their questions and uncertainty about the presentation that I'm explaining to them and the objective findings that I'm interpreting, uh, really helps me look at something a little bit differently. So I think that collaborative growth with colleagues is super valuable.
Well, I think it also creates a little bit of a more objective lens, and like I'll have that with some of my associates here, where they'll come in and like present a case to me. I'm just like, oh, dude, just go do this and this. And I swear, like they're more effective at applying that than I am because I'm not like I don't have all of the information sometimes. Where it's like, okay, cool, you give me the most pertinent things, and then sometimes it's almost easier to be like, no, with certainty, try this, fix, address that. And so I feel like sometimes getting that little bit of input from someone else who's not as involved with the case is actually
Mm-hmm.
very valuable.
Yeah, for sure. Two brains is better than one.
Yeah.
Yeah. Awesome, man. So again, thank you. Let's connect in a couple months and talk a little bit more about your stuff, and maybe we'll tie Kyle into this. Maybe we'll get a little
Uh
group chat going on,
oh.
have a little
Sounds good.
powwow. Maybe even get one of the RTP students out and see how they're doing, because I imagine a little bit of a different experience taking this course as a student, when you don't have a caseload of patients to immediately apply
Hmm.
it to. So be good for us to get together and chat. Anyways, I appreciate it, man, and
Yeah,
we'll be
man.
in touch.
Sounds good.
Take care.
You too, man.